Bismillahirrahmanirrahim. I'm Dr. Mohammad Ishaq Khan, Fellow, Ishaq Institute of Cardiology. I'll talk about a case of PTMC which we performed with anchor wire technique. So we had a 22-year-old female patient who had rheumatic heart disease, was in atrial fibrillation. She had severe mitral stenosis, mild regurgitation, and she was dyspneic with NYHA class 3. So after discussion, she was planned for PTMC. Pre-procedure transthoracic and transesophageal echo showed mitral valve area of 0.7 centimeter square, mean gradient of 14, iliac diameter of 5.2 millimeters, moderate tricuspid regurgitations, high pulmonary arterial pressures, no LA or LV clot, good Wilkins score, and good LV functions. So right femoral axis was taken as routine. But after crossing the interatrial septum, mitral valve, we came across crossing the mitral valve with balloon using the standard technique. We tried it with safer supportive wire, but that didn't help us as well. So after struggling for some time, we considered our options again. So the literature answers us with a few options. There is case report of using double loop technique, which you all may be aware of. If you have big enough LA, then you can double loop the NOI balloon catheter, and it can give support and then direct the NOI balloon into the mitral valve. Another case is reported of using a Swansgan's balloon flotation catheter guided by the left ventricular pressure to locate the mitral valve orifice. Over the wire, pre-dilation with peripheral smaller balloons is also being used before actually using the NOI balloon to do the proper, the final balloon dilatation. And then you have the veno-arterial rail method, which is also reported in the literature, in which a glide wire or an exchange length glide wire is taken and is crossed all the way into the aorta. Then we have another modification of this same technique, which is the anchor wire technique, and it was reported in 2017 in Indian Heart Journal. Basically, what they did was they took a 0.025 glide wire and ran it down all the way into the right ulnar artery and asked the patient to flex the elbow to manually anchor the wire over there, and it then gave them enough support to slide the NOI balloon past the mitral valve. So we did the same approach, and but we used BP cuff inflated on the right arm to anchor our glide wire. So this is done by taking exchange length wire over an JR4 guiding catheter, which takes the wire from the LA into the through the mitral valve into the LV, and then into aorta, and then subclavian artery and down below the elbow of the patient. So then we applied a BP cuff and inflated it above his normal arterial pressure, which we took from the catheter, the pigtail catheter placed in the aortic root. So this was the final position of the wire. But I would like you to note here that the wire is lax at this position, at this point. You shouldn't be keeping it tight. You should release the anchor after you slide the wire. After you slide the NOI balloon past your mitral valve into the left ventricle to get a nice apex to base position of the NOI balloon. Because if you do not keep in mind that point and you keep the anchor tight and the wire is taut, so the balloon will and the wire is likely to avulse the mitral valve apparatus or the aortic outflow tract. So a Swiss cheese sort of deformity can have, and that will be then a surgical emergency. So before actually inflating the balloon, you release the anchor, whether you do it by flexing the elbow or tying a BP cuff around the arm or snaring the wire into the descending aorta. You should release the wire before actually balloon dilatation. So this is the balloon dilatation then. and the procedure was completed without any complications. The patient did well after that, and patient's mitral valve area by planimetry was 1.7 centimeters squares with mean gradient of 4 mmHg and moderate mitral regurgitation. So the anchor wire technique in difficult to cross mitral valve during PTMC, this can be used safely for a successful procedure. Thank you.
Any comments from experts?
No words for comment. I think we can take the comments from Peshawar Institute of Cardiology team. If you have any comment.
No, I think we have the experts amongst us, especially for structural heart. Okay. So yes, we would
like to have Irfan sir would like.
Yeah, because the
Irfan sir.
The PTMC usually.
Excuse me, I am Dr. Irfan. This case, this was beautifully done. This thing I presented here last year in the this PSIC, and I think in 2017 in America. I have made an algorithm in which it is very crystal clear what if you can't cross the mitral valve. There is probably you will find it on the site. There is an algorithm where you go, how you go. If suppose the balloon gets stuck, you can't go, and then you make a curve, you make a reverse loop, then how to go with the wire, with a free wire in the descending aorta, then going with the BP cuff. And then also another, I suggested that you can trap with a balloon in the subclavian artery. So this is all available in my presentation, and there is in the algorithmic form. If somebody needs, I will provide to them, or it is available on the site of this and also on Sky.
Thank you, sir.
Okay.
I would love
Great comments. In fact, that's exactly the question that I had in mind. That obviously we have got other techniques available. Reverse loop is one of those. So why didn't we go for those techniques? Was this the plan to straight away jump for this, or we have already planned those things?
Okay, thank you. Just thanks to Professor Afonso, because he was just our mentor and he supervised us in PTMC. That is what the innovation came. So usually the PTMC is just can be done through normal when we are just able to cross the mitral valve with the NOA balloon. But sometimes it is very difficult just because whenever there is the mitral valve area is less, especially if it is less than 0.6, so sometimes it is very difficult to just cross over the NOA balloon through the mitral valve. So we have to offer different technique, as Sir Afonso mentioned. Sometimes the AV rail from the arteriovenous, we have to snare in the descending aorta. Sometimes just we have to anchor in the brachial or some artery. But as far as this case is concerned, so this is very cheap and the easiest way that we anchor the wire, and just by the support of that wire, we can slide the balloon from the LA to the LV. And it was quite nicely done, and the patient was all right and was discharged on the second day. Thank you.
Is there any preference of wire for the use for this purpose? And second, is this NOA balloon compatible with all the coronary wires?
No. The wire used was just 0.3 or 0.035 Teflon wire, just the normal wire we are just using for the angio, for the angiogram. This is just the same wire, but that is the 260 centimeter long exchange wire.
Okay, Dr. Alidada, sorry. I have the similar, because I have a similar comment regarding this wire. So while in the LA you use the JR to cross the mitral valve?
Yeah, okay. Sometimes because the issue is that we have to cross the mitral valve through the balloon, but we were unable to cross the balloon. So first we have just crossed the wire, the Teflon wire, from the LA to LV, which was then moved to the brachial artery.
Was it a glide wire?
Yeah, this was glide wire 0.035.
With a small J-tip bend, sort of.
J-tip, 0.035 glide wire, the Tiromo, just like.
And while in the LV, then when you have to go to the cross the aortic valve and go into the aorta, so again, what's the maneuver for that? Because this is an excellent, case, learning case over here. And this is what I am asking for my personal learning. Sometimes it's very difficult to cross the mitral valve. So once the wire is inside
otherwise
the
it's
LV,
quite a heavy wire,
so
although it's a guide wire, but it's quite a heavy wire, and you are exerting a lot of force actually on that. Is there any literature on any complication of this kind? Because as Dr. Saab has mentioned that it's in the algorithm, you can get this kind of support by extending the wire.
Whenever we are just doing the post-impact VSD, the same technique is used just as a AV rail formation. We just cross the wire from the right side to the left side. This is just the same technique, but the glide wire is quite easy just in moving. And as Dr. Ishaq mentioned, that whenever we have the anchor the wire at the brachial artery, where we have glide the balloon from the mitral, from the LA to LV, at that time we have lex that glide wire, because that is the point where you are not able to lex, you can just end up with the severe mitral regurgitation. So when we are just inflating the balloon, first we have to lex that wire. So you have just to remove the cuff and legs, and after that you have to complete the procedure.
Great case, definitely, wonderful.
Thank you, sir.
Thank you, Ishaq. Very nice case with an innovative technique. Now we are moving on to the next case, TAVI, a bumpy right. Muhammad Qasim Khan, NICVT.